All right, welcome everyone. Good morning. Thank you for joining us today. We're glad that you could be here for the third installment of the Department of Correction Insider Series webinars. Our topic today is substance use disorder treatment and medication-assisted treatment. My name is Heather Zwickert, and I'm the Chief of Planning, Research, and Reentry Unit at the Department of Correction, and I'll be your moderator for today. Planning, Research, and Reentry is a specialized unit in the Office of the Commissioner that leads the department's data collection and analysis efforts, facilitates strategic planning, oversees the department's accreditation and compliance, and provides project management for multi-bureau initiatives set by the Commissioner. The unit has also been assigned the task of expanding and improving prisoner reentry initiatives within the Department of Correction. Today's presenters are Deputy Bureau Chief Mike Records and Dr. Awe Maduka from the Department of Correction, and Rochelle Johnson and Eric Robinson from Centurion. Mike Records is currently the Deputy Bureau Chief of the Bureau of Healthcare, Substance Abuse, and Mental Health. He's worked for the DOC for 30 years. Mike holds a Certified Correctional Manager credential through the American Correctional Association. He began his career with the DOC as a probation officer in 1991 and has served in various capacities within the DOC, including probation and parole supervisor, social service administrator, planning manager, and the Deputy Bureau Chief of Community Corrections. During his time with the department, Mike has worked in program development and management, offender reentry, accreditation and compliance, policy development, and grant management. Mike is a graduate of the University of Delaware and Wilmington University, and he serves as an adjunct instructor for Wilmington University as well as Delaware Technical and Community College. Dr. Maduka joined the Department of Correction in July 2018 as our medical director. Prior to that, she was the state medical director for the Delaware Division of Public Health and an attending physician in the Department of Internal Medicine at Christiana Care Healthcare Services. Dr. Maduka obtained her medical degree from the University of Ibadan and holds a master's in public health from Harvard University and a PhD in disaster science and management from the University of Delaware. She's board certified in internal medicine and infectious diseases. Her work relative to the Delaware opioid epidemic started in 2016 while at DPH, where among other things, she worked as a key member of a multi-agency team focused on expanding access to harm reduction services and early testing and treatment for diseases associated with injection drug use. Since coming to DOC, her focus relative to SUD has been on expanding access to medication-assisted treatment for persons with SUD. Rochelle Johnson is the statewide director of the Substance Use Disorder Program for Centurion, who is the contracted provider for behavioral and medical services for the Department of Correction. Ms. Johnson is a master's level social worker and certified drug and alcohol counselor. She has worked in SUD programming in the Department of Correction since 2006 in every capacity, both administratively and clinically. She currently provides oversight and support for all level 5, level 4, and aftercare SUD programs within the department. Ms. Johnson has a passion for working with justice-involved populations and views her job as a service to our clients in the community. Eric Robinson serves as the statewide SUD master trainer for Centurion. Mr. Johnson is responsible for training contractual and DOC staff on best practices for empowering incarcerated men and women on how to utilize therapeutic community practices to sustain engagement in the process of self-change. He's a master's level social worker, community advocate, skilled trainer, and motivational speaker. He's provided leadership and oversight for numerous SUD programs in Delaware, Pennsylvania, and New Jersey. And he has over 10 years experience working with at-risk, vulnerable, and oppressed populations in both the prison and community settings. Today's agenda is going to include a historical perspective on substance use disorder programming in the Department of Correction, an overview of the recently redesigned SUD programs, and the expansion of medication-assisted treatment for opioid use disorder in the department. We'll give some information about ways to get involved and get connected. And at the end, we will have a period for question and answer. Please submit any questions that you have through the Q&A box on your Zoom screen versus the chat screen. And we will select some questions that are submitted through the Q&A screen and pose those questions to our presenter at the end of the session. Due to the large number of attendees that we have, we likely won't be able to answer everyone's question, but we will attempt to respond to as many as possible during the webinar And ones that we aren't able to answer during the webinar, we'll try to follow up with you via email afterwards. So if you have the option also to ask your question anonymously, but if you want us to be able to answer it after the fact, you would have to ask the question identifying yourself. The webinar is being recorded, and we will make the recording and the PowerPoint available afterwards. It will take a few days, but we'll have the PowerPoint and the webinar available for viewing after the fact. And we'll also apply certificates of attendance for those who stay tuned for the entire webinar. On your screen now, you'll just see a slide that indicates the facilities that we have here at the department, our level 5 prison and jail facilities, and then our level 4 facilities that we'll be talking about programming that happens inside these facilities. Today, we're also going to be conducting some polls during the webinar to keep things interactive. All the answers to the polls are anonymous. And for our first poll question, we'd like to get a sense of who's joining us today. So as a check-in, we are going to invite you to click on the poll that will be appearing on your screen momentarily and tell us which stakeholder group best describes you. So let's see, we should launch this. All right, so hopefully the poll has launched and everyone can see it. Yes, people are voting. Okay, so we'll give it a minute. And then this will give us an idea of who we have in the audience. Looks like we have a lot of DOC employees with us today, a lot of members of nonprofit organizations, other state agency employees. Just give it another second. We have about 83% participation in the poll. All right, thank you everyone who participated. I think that I hopefully have shared the poll results with you. So our participants today are mainly from the Department of Correction. I think that's always great when we have DOC staff interested in learning more about parts of the department that they might not have a lot of information on. We have other state agency non-DOC employees with us, a good amount of nonprofit members. So thanks everyone again for joining us. And we will do, I think, 4 or 5 polls throughout. All right, so now I am going to turn it over to Deputy Bureau Chief Mike Rickards to begin discussing with everyone the substance use disorder programs with the Department of Correction. All right, Mike, there you go. And just let me know whenever you want me to advance. You're still muted.
Can you hear me now? Okay. Good morning. The Delaware Department of Correction, about 2 years ago, started an initial redesign group. Consisted of the vendor that we had at the time, along with DOC personnel from both the Bureau of Community Corrections, Bureau of Prisons, and Bureau of Healthcare Services. When we changed contracts in April of 2020, Centurion became our new vendor, and we essentially reinitiated that redesign group at that time. When we did, we were able to leverage some of the expertise of Centurion from around the country. The coordinator of SUD treatment for Centurion was part of that work group, along with a couple other PhD level individuals from various parts of the country. And so working together, it took us from April of 2020 until November of 2020 to come up with a design that we were happy with. We considered several different things in making these changes, and that implementation went into effect in November of 2020. Because of what has been happening in the country with the pandemic, there were some starts and stops in that process, and I think probably around the beginning of February was when the new redesign program really started to take effect. So we previously had a SUD program that was known as the KEY program. The KEY was delivered at level 5 institutions. The CREST program was the level 4 version of the KEY delivered at level 4, and it would definitely be a shorter term of treatment at the CREST program. KEY started in the early 1990s, beginning first as the prison now known as Howard R. Young Correctional Institution. Shortly afterwards, there was something called the CREST Outreach Center that was put in place at Plummer Community Correction Center. KEY and CREST was a multi-phase residential substance abuse treatment program for drug-involved offenders. The program consisted of behavioral and cognitive behavioral therapy delivered in a therapeutic community environment. Aftercare was added for both KEY and CREST participants who completed the program. Next slide. So the design established a continuum of either KEY, then CREST, then Aftercare, or KEY or CREST followed by Aftercare. The continuum, or the triumvirate, essentially consisted of all three, which would take a person approximately 2.5 years to complete. And so over time, that kind of eroded a little bit. And the courts, who were the primary driver of who went into those programs, decided they would want somebody to do only the KEY or only the CREST, but that always was followed with Aftercare. The program, KEY and CREST, was researched extensively by the University of Delaware. In fact, the University of Delaware was one of the partners with the DOC in how the program was researched and got implemented here to begin with. The program changed several times over the years, including oversight by multiple different vendors. And there were various things that were added and subtracted from the program. And so as research changed about therapeutic communities, we changed with those. But then also, I think we made some changes that weren't necessarily following with research. And so when we started our redesign process, we wanted to bring our SUD programs in line with what the current research is on SUD treatment. So next slide. And so in the 2010s, I believe around 2010, 11 or 12, the DOC began something called the Delaware Justice Reinvestment Task Force. And the key, or the goal of that task force, was to look at things that would reduce recidivism in Delaware. We were assisted by the Bureau of Justice, Institute of Justice, and a lot of our data on recidivism was analyzed, and several recommendations were made to the Department of Correction. I think that's it for this slide. And so here are some of the things that came out of that Vera Institute help. DOC adopted a risk need responsivity tool, the R&R, to work in conjunction with the level of service inventory revised, or the LSIR. The LSIR is a risk needs assessment, which is essentially scoring somebody as a high, medium, or low chance to recidivate. DOC also incorporated fidelity monitoring of programming using the California Program Assessment Process, or CPAP, and the Correctional Program Checklist known as the CPC. By 2019, DOC looked to redesign the KEY CREST programs to align with evidence-based best practices and programs. DOC and Centurion, the DOC medical and behavioral health vendor, began to collaborate. Okay, next slide. So items identified for the redesign included the role of assessments in program placement, the delivery of different treatment dosages within the same program, varied lengths of stay for each dosage level, the removal of work release portion of level 4 for the participants in the level 4 portion of the program, and the use of an evidence-based cognitive behavioral therapy within the modified community. And so let me just talk a little bit more about this slide. So in the past, the DOC, as I mentioned, primarily got people into these programs through sentencing orders. The other key way that they got into the programs was being classified by DOC counselors and classification staff. And so we knew that that was not evidence-based, that the thing that we should be doing is assessing a person. And so that in November of 2020, after communicating with the courts and communicating with other stakeholders, we began a process of using the LSIR followed by the risk need responsivity tool that we have built within our DAC system to determine which of several buckets, if you will, of treatment would be most appropriate for the offender to reduce their recidivism. And so one bucket is intensive substance abuse treatment. Another one is cognitive behavioral therapy to deal with criminal distortions and thought processes. Another one is vocational training. And there's a couple other that I can't remember the name of right now. But so the R&R would essentially say this person does need substance use treatment. And then the next portion would be that the assessment counselor from Centurion would come and meet with that person and determine how severe the person's addiction was. So LSIR and R&R gets you to the point of where it's indicated that you need treatment. And then the last process was to determine which track, whether you needed a residential level of care, a intensive outpatient level of care, or an outpatient level of care. And the way we talked about the program as we were designing it, we believed that we could do all three within the same program with different dosages and with different lengths of stay in each one. Okay, so from this slide, this is kind of the old way to the new way that I think I went over most of this. So no longer does the court specifically sentence somebody to the new program called R2R, or Road to Recovery. They say DOC discretion. And so that gives the DOC the ability to use these three assessment tools to determine what is the most appropriate treatment for a person. And so for the R2R, so I'm sorry, I'm backing up now. So the key duration was 12 to 18 months. This is the old program key. The old program CREST, the duration was 6 to 12 months. And then Aftercare was approximately 6 months in the community. And so next slide.
I think, Mike, now I think is a good time. We're going to launch a poll real quick.
Okay.
So let's see. Okay. I believe everyone should be able to see this. So the question we're asking right now is about how many people do you believe successfully completed the KEY or CREST program in 2019? 2019 was the last full year that KEY and CREST was run as our SUD program. So we'll just give everyone a minute to answer, and then we'll reveal the correct answer and brief it a little bit. All right, great levels of participation. We really appreciate it. Give it another few seconds. All right, thank you, everyone. So in 2019, we had approximately 733 people who successfully completed KEY or CREST. So 750 was the correct answer. The numbers for 2020, and I think Mike hit on this a little bit, the numbers for 2020 completion were a little lower, and I think several factors, were contributing to that. Our change in practice from court ordering the programming to the department placing people in programming based on risk needs and clinical assessments, pauses in classification due to the COVID pandemic, and decreases in admission to the department's facilities due to COVID-related court closures. So I think that, all of those things could potentially play a role in why the numbers were down a little bit for 2020. And then we'll, as things start to return to normal, we'll be able to take a look at 2021 as things hopefully start to reopen. So thank you again for participating in that assessment or in that poll. And I will you have your next couple of slides are on the LSIR and the R&R. So just let me know how you when you want to flip.
Okay. So let me go back because I don't recall where my information is on the tracks. So let me cover it on the last slide just real quickly, and I'll give a little bit more information if it's a couple slides ahead. Can you go back one slide? So what we came up with was a track system. So track 1 is residential level of care, and at level 5, that is anywhere between 9 and 12 months. Level 2 is an intensive outpatient level of care, and that is between 4 and 6 months of treatment. And then track 3 is an outpatient level of care, and that can be anywhere from 2 to 4 months of treatment. And it's all based upon meeting certain benchmarks, and once the person is successfully deemed by treatment staff to have completed, they can be released. And so before, there was very much adherence to, they stayed the entire length of the program, regardless of the benchmarks that they may have been meeting. And so that's another key part of the redesign. They have the ability to meet those benchmarks, receive the blessing of the counseling staff that they have learned what they need to learn in the program, and then to be released primarily to aftercare. But also in our redesign, we allowed the treatment staff in the programs to recommend a person that didn't necessarily need aftercare, or maybe aftercare wouldn't be enough for them. They had no more time, so the ability to send people to treatment programs in the community that were not aftercare was also a part of the redesign. Okay. And so you can see here that the number of hours per week. So using the University of Cincinnati program checklist that I mentioned earlier, we were looking for at least 35 hours of treatment per week in our level 5 R2R program. Just a little bit less than that in the level 4 program. The research is saying that anywhere from 30 to 50 hours is the required amount per week that a person should have, due to the ability to program that many hours in a week. It's difficult inside of a correctional facility. So 30 to 35 was an achievable goal for us. And so 9 to 15 hours is what's expected for track 2. 9 hours per week is for track 3. They do program sometimes together. The other key is that for level 5 men, track 1 is at Howard R. Young, and it is a program that is there by itself. The other 2 tracks for men for level 5 are at SCI. So track 2 and track 3 are at SCI. For women, BWCI and HDP, they have all 3 tracks working together there. And for level 4, we no longer do SUD treatment at Plummer Center or at Sussex Work Release. All the treatment program for R2R is done at our newly named Community Correction Treatment Center, or CCTC. So next slide, Heather. Okay, so some of the things that we had taken into consideration were concerns expressed by former Key and CREST participants. To address these concerns, different curriculums are now dedicated to each program and track. So they had complaints that when they did the Key program and transition to the CREST, their belief was that they were just repeating the same material, that it was just being done for another 6 months. So we looked at curriculums that we could use that were different at level 5 and level 4. and we looked at something that they could actually take away with them, do homework in while there was downtime in the programs, which also came in very handy during the pandemic. They were actually able to do journal work out of these research-based journals while we were having to lock down because of COVID. So the University of Cincinnati Cognitive Behavioral Core Adult Curriculum is the largest curriculum, most intense curriculum that's being used, and it's being used at level 5. The TCU Institute of Behavioral Health Comprehensive Interventions is also being used at level 4, and the Change Company journals our journaling system is being used at both 5 and 4. And that's something that we call our collegiate model. And the reason that we call it our collegiate model is because it allows people to kind of pick things that they think are most important to them personally. So if somebody believes that they're in denial, or if they believe that they have mental health issues, or if they want to get started on MAT treatment, medication assisted treatment, then they might pick that as one of their collegiate model groups. And I think I'll turn to Eric now and ask if he could just give a little bit of information about the change from the previous curriculums to the TCU, to the CBI, and to the Change Company journals. What benefits it's given us. I think Eric can really talk well to that.
Good morning. I think our previous focus with the material we use, for example, we've used stages of change in the past. One of the concerns with it is if we just had a packet that talked about stages of change, it was left up to the facilitator, the practitioner, to kind of dispense the information in whatever manner. So there was no, for example, the biggest difference with like Change Company material or the other material that he mentioned, because there's 3 separate curriculums. There's facilitator guides that allow for the practitioner or facilitator to prep before the group, so they can actually use the facilitator guide, line it up with the workbook that they're working in for the group, look at what page they're on, and it kind of gives them tips and understandings. For example, we now use what's called a structure board system as a template to do group. So similar to like in college, you may have an instructor write up on the board the topic, the duration of the group, bullet points of what will be covered. More importantly, kind of objectives or learning objectives. So now what happens is the material is just more experiential. It's in bite sizes, meaning we don't overdose clients with information or kind of inundate them, talking to them for 90 minutes at length. It's designed to be more experiential for the client, where they're actually able to be a part of the dialogue while we're talking about information. For example, one of the workbooks is called Community in the Level 5 Track 1 program, which is R2R. A resident that initially comes into the program is given a workbook called Community. They're asked to do about 3 pages per day. They're now assigned to what is considered the orientation phase, because that particular track goes in phases. During that time frame, they're actually allowed to come to group and actually learn about how the community should function. It talks about community as method in that model or in that workbook, and it just gives them an opportunity to kind of lower their defenses and to feel empowered about being a part of their own change process. Previously, we just kind of shared information kind of with the hope that they would self-actualize it, and it took a lot of guidance and direction from the staff to get there. Kind of one of the key principles of therapeutics or TCs is the community should be healthy enough if it forms in the stages it's supposed to go to. Initial stage is pseudo community. The next stage, is focusing on functioning for the community, and then you get into community forming. After the community actually forms, it starts to do a process called being both the teacher and the healer. That's where you see people that are in the program for longer length of time being big brothers or big sisters to people that come in. And then basically the final stage is they reach community, and they literally are the healer and teacher for each other. Why is that so significant for us? Working with this population is significant because this population returns to our communities, and the reality that they will engage with one another before they engage with one of us is important. If we don't educate them in a way to make healthier choices, they've now returned to our community with misinformation that doesn't give them the ability to make healthier choices. So that's kind of the biggest difference between how the curriculum is used and kind of the upgrade in the material that we use now.
All right, thanks, Eric. And so Heather's put these 6 of the collegiate model components up on the screen. So one is dealing with trauma, one is dealing with anger. I already mentioned the MAT. One is dealing with co-occurring disorders. So if somebody has some kind of DSM-5 diagnosis, depression or anxiety or something else, then they might select this as their journal series that they do. And then another one is healthy relationships and life skills. And so next slide, Heather. So the program participants receive a discharge summary with the completion record and continued treatment recommendation. And so that information now is shared almost immediately with the probation officers in aftercare, as well as the aftercare counselors. So by the time the person makes their first visit to either aftercare or probation and parole, the officers there already know that person a little bit from what they're able to see in our shared file that we have to distribute this information. So flow to the next level of care. If somebody is determined when they leave the R2R at level 5 that they don't need to go to level 4, and there's no level 4 on the sentence, then they go to aftercare in the community. If there is level 4 on the sentence and the counselors believe that the person needs a little bit of help at level 4, they could do the same level of care that they were doing at level 5, or they could go into one of the other 2 tracks. And so just for example, if a person is at level 5 at Howard Young, completes that program successfully, the counselors do an assessment and they believe that he needs just a little bit more help in the community and there's a 6-month level 4 sentence to follow, they may recommend that he do an outpatient level of care at level 4. And so then that person could go to CCTC, do the 2 months there as an outpatient level of care. If it's believed that he's done enough and completed all the benchmarks there, then he may be able to go to work release to finish the last 4 months of that level 4 sentence. And so I think I had said earlier about the change company journals. So a person may do what Rochelle, maybe 3 to 4 different journal series while they're in a program, maybe more than that. And they're actually able to take those journals with them so that hopefully when they get to the community, if they're struggling or if they think they need some information that they were able to come to grips with while they were in the program, they have the ability to go back and reference the things that they were doing while they were in the program. Next slide. Okay. So one of the struggles that had existed previously for some individuals was that there was a break in care. And so in the old program, if you completed a program at level 5 and there was a huge break, you didn't really go to aftercare afterwards. And so we realized by the way we had redesigned this that somebody may have a level 4 sentence to follow their level 5 time. And we wanted them to be able to start aftercare right away. So if that person completed level 5 R2R and the counselors believed that they did not need to go to level 4 to do any additional treatment, they could go to level 4 and begin aftercare when they got there. So that's another one of the key changes that we've made to the program in this redesign. Next slide.
So Mike, I think that's your last technical slide. So I don't know if there was anything that you wanted to add before we turned it over to, if you or Eric or Rochelle had anything they wanted to add before we turned it over to Dr. Awe to talk about medication-assisted treatment.
I think that's it for me, but Eric, Rochelle, anything you want to say? All right. Thank you.
All right, so Dr. Awe, if you'd like to kick us off talking about MAT.
Sure. Good morning, everyone. So I'm going to be discussing with the group about medication-assisted treatment. So like most people know, medication-assisted treatment is the use of FDA-approved medications along with counseling to provide a whole patient approach to treating opioid use disorder. And the goal of MAT is really full recovery of the patient and the patient being able to live a self-directed life. Next slide, please. And so there's, no, the one before, yes, that one, thank you. There are 3 FDA-approved medications for the treatment of opioid use disorder. Most people are familiar with these: methadone, naltrexone, which is commonly known as Vivitrol, and buprenorphine, which most people know as Suboxone or Subutex. Now, these medicines treat opioid use disorder by normalizing the brain chemistry. So like most people know, what happens with addiction is that over time, there's changes to the way the brain functions. And so these medicines, when they're given, they help to bring that back towards normal over time. The other thing they do is that they block the high that people get from opioids. They reduce cravings and help to normalize the body functions. Next slide, please. And so these are the 3, again, FDA-approved medicines. Vivitrol is a monthly injection that's given into the muscle. Buprenorphine comes in different forms. Many people are familiar with Suboxone or Subutex, which is given by mouth. And that is either a pill, which is placed under the tongue, or a strip, which is placed under the tongue. And the oral form, the forms that are given by mouth, are given every day. And then Sublocade is an injection that is a monthly injection. Methadone comes in different forms, but the formulation that's most commonly used for MAT is a liquid concentrate that's given by mouth on a daily basis. Next slide, please. The other thing I wanted to talk about is Naloxone. Now, this is not used for MAT, medication-assisted treatment. Instead, it's used as an antidote, if you will. So in situations when a person has overdosed, this is when you want to use the naloxone. It is what is called an opioid antagonist. And what it does is that it reverses the life-threatening effects of opioids, things like the altered mental status, the depression of breathing, those things that could lead someone to die from an overdose. Naloxone acts very quickly and reverses that. It's commonly known by the brand name of Narcan, although there are other brand names out there. And it may be given into the nose or into a muscle. If a person is admitted to the hospital, they could also give the naloxone into a vein. Now, in 2018, DOC probation officers started carrying naloxone, and they have used this. They've been able to deploy this to help save several lives. Just earlier this year, in February of 2021, we also began to distribute naloxone to inmates as they leave. And so as people are being discharged from DOC, they're offered naloxone kits, and they can accept them or they can refuse them. And in the 6 months since we started this, we have given out over 1,800 naloxone kits. And so that's potentially 1,800 lives out there in the community that could be saved with the naloxone kits. And when we give these out, it's not just to those with substance use disorder, because we realize that an individual may not themselves have opioid use disorder, but they may have a friend or family member that they could use this to save. And so this is one thing that we've been able to accomplish, and we're very proud of, and contributing to hopefully lives being saved out in the community. Next slide, please. And so the medication-assisted program here at DOC has undergone a significant evolution over the past 3 or 4 years. Before I go into that, I did want to just put out some definitions. These are my definitions just so that everyone understands what I'm talking about when I use these terms. And so when I talk about MAT initiation, what I'm referencing is opioid use disorder patients who were not on treatment, but who come into DOC and we start them on medications to treat their substance use disorder. And when I reference MAT continuation, these are individuals who before incarceration were already being treated. They might have been on methadone, on Vivitrol or Suboxone, and they come into us and we continue their treatment. I will also be talking a little bit about guest dosing, and what that is on some occasions, particularly as regards methadone, if someone is already on methadone in the community and comes into our facilities, then we work with the community MAT providers to send the daily doses so that we can administer that to those patients. Next slide, please. And so prior to 2018, what we did here in DOC, and this is very similar to what has been happening in correctional facilities across the country. And actually in many jurisdictions, this is what is still happening. So before 2018, the only people that we started on MAT were pregnant women. And the reason why we started pregnant women was that everyone realized that if a woman is addicted to opioids and you suddenly stop that, it could significantly affect the baby, and the baby would have neonatal abstinence syndrome, which is life-threatening to the child. And so we would always initiate pregnant women who had substance use disorder on MAT. Now, with regard to MAT continuation, so someone was on MAT in the community and then came in, at the time, the continuation was infrequent and sporadic. So most people would come in and would actually just go through withdrawal. And so if you've had a patient or a family member or friend who has substance use disorder, I'm sure you know that withdrawal can be a very difficult and painful experience. But that was really the mindset at the time. Everyone had the mindset that we should keep drugs outside of the walls, including the MAT drugs. But over time, and next slide, please. Over time, we have begun to change that mindset. And so a big change happened 2018 through 2019 under the excellent leadership of Dr. Mark Richmond. This was really his vision that we should treat people and not just withdraw everyone. Now, some people are appropriate for withdrawal, and some people do want to be withdrawn. But for those for whom treatment was appropriate, he wanted to make sure that they had access to treatment while at DOC, similar to what they would have in the community. And so there were several months where we really focused intensely on staff education, both the healthcare staff, the correctional staff, and the idea was to change the mindset, change the culture. And so what happened between 2018 and 2019 was that we then, of course, continued treating the pregnant women with MAT, but then we gradually started expanding to the non-pregnant women. And so the non-pregnant people, men and women. And so we would start some people on Suboxone, and we would start some people on Vivitrol, depending on what was appropriate for their situation. We also began to expand continuation of MAT. So someone in the community on MAT would come in and we would continue that. The other thing we started doing was for those people for whom withdrawal was the appropriate thing, either because that was what they wanted or because the doctor assessed them and determined that that was best for them, we started using Suboxone to support the withdrawal so that it was much less painful and stressful than allowing them to just abruptly stop. Next slide, please. And so that brings us to where we are now from 2020 to the present time. We've continued to expand MAT, and we've really ramped up the numbers who are newly started on MAT. Now, it's expected care that everyone who's on MAT in the community, when they come into us, will be continued on the MAT. We continue to provide education to inmates, to staff, healthcare staff, security staff, and we've also developed protocols and procedures so that we standardize things across our facilities. Next slide, please.
Dr. Awe, we're gonna actually take a break right here to launch a poll before you go on to your next slide. So poll 3. So Dr. Awe just spent some time talking about how DOC has expanded MAT in the department between 2018 and 2021. So the question for the poll right now is the average number of individuals per month receiving MAT while in DOC custody has increased by what percentage between 2018 and 2021? We'll just give a little bit for people to answer. And again, really appreciate the participation. We have a lot of people responding. Okay, we'll wrap it up in just 1 second. All right, thank you, everyone. So let me share the results with you. So the majority of respondents picked 150% increase in the average number of individuals per month receiving MAT, and the actual increase, and Dr. Awe will talk about this in the next slide, was over 400%, which I think really demonstrates the department's commitment to the whole patient approach to treatment for SUD disorders. So thank you for participating. And Dr. Awe, your next slide.
Yes, thank you. And so what you're looking at on this slide is the number of people being newly started on MAT each month. So you can see in 2018, on average, each month we were starting 24 people newly on MAT medicine, but that has gone up this year all the way up to 124 people newly started on MAT each month. I did want to mention the reason for the asterisks for 2018 and 2019 is that at the time we were not as good with data collection as we are now. And so we believe that some people may have been counted twice if they moved from one facility to another facility and the medicine was reordered, it would have been inadvertently counted twice. So it's very likely that the increase is actually higher than what we're seeing here. Next slide, please. And so this is just another way of presenting the same data. 2018, we were starting an average of 24 people on MAT meds in a month, and now we're up to 124. Next slide, please. And so there's different paths, 4 different paths to a patient being placed on MAT in DOC. The first one is a substance use, opioid use disorder patient in the community who comes into DOC already having been started on MAT by his doctor, his community provider. And so he comes in, the nurse takes a history from him. And what the nurse does is that the nurse reaches out to that community provider to confirm the dose, to confirm the medicine. And then the doctor here then orders the medicine and we continue the person on MAT. The only exception to that is methadone, and I will explain a little bit more about that in the next slide. But for methadone, we are actually not at this moment, DOC doctors and providers are not able to write a new prescription of methadone. There are a few exceptions, but for the most part. And so for people who are on methadone, when they come in, we work with the community provider to send that dose into us. The other pathway is a person who has opioid use disorder who has never been treated. He's not on MAT in the community. The nurse obtains the history, determines that this person likely has substance use disorder. Then the nurse makes a referral to the physician and also to behavioral health. And then the doctor assesses and can start the patient on Suboxone, Subutex, or Vivitrol. Again, as of today, we are not able to start a new prescription of methadone because we're not yet a licensed opioid treatment provider. And again, I will talk more about that. But the only situation in which we're able to do that, we have worked with our contract pharmacy to make sure that no one ever has a break in their treatment. And so if someone is on methadone in the community, we are able to provide 3 days worth while we wait for the community provider to send them their medicines. Now, if a patient comes in and has substance use disorder, and for whatever reason, they were not started at intake, maybe they refused, or maybe it was considered to not be appropriate at that moment, or maybe they were in-house, they were here with us before we started the MAT program in 2018, that individual can request to be evaluated for MAT by submitting a sick call or doing any of their medical visits. Now, if the patient has been in DOC for less than 6 months, the doctor will evaluate and may start them on Vivitrol or Subutex / Suboxone. If they've been here for more than 6 months in DOC, the doctor will evaluate and may start that person on Vivitrol. Next slide, please. The fourth pathway, if you will, to people being started on MAT is pre-release, just before they get sent home. So if a patient is known to have substance use disorder and was not previously on MAT, they could get started within 60 days of their release. They could put in a sick call request to see the doctor, or as part of their discharge planning while meeting with the reentry providers, they may request MAT. And so what would happen is that they'll be evaluated by the doctor, and as appropriate, they could be started on Vivitrol, or they could be started on Subutex. The other thing is that we've worked on in the past several months is that now when we have patients who are on buprenorphine, Suboxone, or Subutex, we're now able to send them home with up to a 5-day supply of Suboxone, and that's to cover the time before they get to see the community provider. And we work very hard to make sure that people on MAT are connected to community resources so that there's not a break in their MAT. We're working very hard to become a DEA licensed OTP. That would allow us to be able to prescribe methadone for our patients for whom this is considered to be the best choice. Next slide, please. And so there's nothing that's without, no, the next one, thank you. There's nothing that's, that doesn't have challenges. And so as we've rolled out the MAT program and expanded over the past 3 years, we have come up against some issues. One is the issue of diversion. And so we've had different approaches to try to prevent this, to try to tackle it. One is that we have each patient sign a diversion agreement. And so basically they understand that if they're caught diverting their medicine, their dose could be reduced, or they could actually be stopped depending on what the assessment of the doctor is. The other thing is that we have specific times when the nurses dispense the MAT medicine. So we call that the MAT med pass times. Those are specific times, and it's not done at the same time as other medicines. And we're very careful with doing mouth checks. So people get their MAT medicine, they sit down until it's absorbed, and then they have mouth checks to make sure that, to reduce the chances that people will save it for later and divert it. Another important challenge is that MAT medicines are very expensive. But we realize that DOC is a crucial component of the statewide effort to prevent SUD deaths. And so we're treating patients regardless of the cost. But we have taken some measures to try to make sure that we're providing high quality care, but also in a way that's cost effective. One that we did recently was that we switched most patients from Suboxone to Subutex. This allows us to have the same active ingredient, which is buprenorphine, available to our patients, but at a cost that is much more cost effective. We continue to provide education to staff because, again, this is something, the prior mindset has been here for a long time. So it's going to take more than 3 years to change. So we continue to educate people to try to change the culture and the attitudes about substance use disorder. Next slide, please. And so we're eagerly looking forward to the future of MAT at DOC. In addition to looking to expand and make sure we have as many people treated as possible, we've realized the need that as we expand this program, we really need a very efficient way of tracking our data. We've improved from what we had previously, but we're working now to improve from manually counting each prescription, each individual, to being able to pull reports directly from our electronic health record. The other thing we're working on is reducing the time from when the person walks through our doors, not previously treated, he walks into our doors, to reduce the time from when he walks in to when he's seen by the doctor and started on MAT if that is appropriate. Like I said, we're working to become an opioid treatment program so that we will have prescribing of methadone as an option. We continue to increase the focus on counseling. You've heard a lot from Chief Records and Eric about this. But just to reassure everyone that we're not just medicating the individuals, but we're really focused on treating them holistically. Next slide, please. And that's it.
That's actually your last slide, Dr. Alway. Thank you very much. I don't know if there's anything else that you would like to add, or Mike, Eric, or Rochelle, if there's anything that you would like to add before we move on to our last polls and then the Q&A session.
No, nothing from me. Thank you.
No, thanks.
Okay, so the slide that we have up here right now is just some contact information for our participants. Different teams at DOC who might be able to answer your questions if you have reentry questions, if you have questions for our victim services coordinator, if you have specific questions, if you have questions about a specific inmate or a specific probationer, you can reach out to our community relations team and they will do their best to contact you or to connect you with the right part of the department to get your questions answered. Just keep in mind, if you're requesting information about a specific person, the community relations team may ask for a release of information, or if you have permission to receive information about the person you're asking about. We don't want to be providing private information to people without permission. So those are up there now, and then, like I said, we'll make the PowerPoint available so you'll have access to those emails. In October 2021, our part 4 of the DOC Insider Series will be Probation and Parole 101. So please, we hope that you could tune in to that and learn some things about probation and parole and ask any questions that you might have on how that process works. Right now, we would like to invite you to provide some feedback on today's webinar. I'll be posting 2 polls in a second, asking to rate today's webinar, and then to also asking about things that you might be interested in learning about in the future. Again, the polls are anonymous, so we won't be able to see who provided what response, so please feel free to respond freely. And for the second poll, you can make more than one choice for the different types of webinars that we will have available going forward. So I'm launching this poll. Please rate how satisfied you are with today's webinar. Excellent, good, so-so, poor. And we really appreciate honest feedback so that we can, provide information in a way that's good for everyone. All right, we'll just give it another few seconds or so. Really appreciate everyone's responses. All right, thank you very much. And then we will launch the last poll for today, which is just asking which of the upcoming webinar topics you're likely to tune into. Probation and Parole 101, sentence calculation and release dates, education in prison, cognitive behavioral therapy in prison, and prison healthcare. And you can respond to more than one topic, so multiple choice response. All right, I'll just give it another second. All right, great. Thank you. Looks like a lot of people are interested in sentence calculation and release dates. So I'll be letting our presenters know that there's a major interest in that and probation and parole, actually like all of them. So thank you for your continued interest. And now we will move over to the Q&A portion here. All right, so bear with me. So one of the first questions that we received was, does everyone coming out of the program have to do aftercare?
No, everybody does not have to do aftercare. The assessment is made by the counselors in the program that they're leaving. And so, for instance, somebody that's got significant mental health disorders, or maybe somebody that completed the program but still struggles, they may determine that they would be better served by a community treatment provider. But the first thought is for aftercare. That's the one that we would lean to most, because it's a continuation of the services that they got inside. But we are definitely flexible, and the recommendation is made by the program for what's the most appropriate treatment for that person upon release.
Thank you. Okay. Next question. Okay, so when someone is assessed using our LSIR and our R&R, and other multiple treatment needs are identified, does the person get those treatment needs addressed as well? And if they do, will that hold up their flow down? So I don't know if anybody wants to touch on that, or if you want me to help a little bit.
So the risk need responsivity assessment is targeting what is the most likely programs in order to be successful at reducing recidivism. So if there were 2 or 3 of those programs recommended, it depends on where the person is in time. So if they have a 10-year sentence, then it's likely that they could do all those programs before release. If there's a short period of time, then we would target the one that R&R says is the most likely to reduce recidivism. And I'm not that expert, and so research and planning has more information about that than I do. So I'll defer to you, Heather, for any other information on that.
Yeah, I think that's a pretty thorough answer, Mike. You know, we have the R&R is going to produce 3 best fit results, and our classification team will then take a look at the individual and make a decision based on numerous different factors, security levels, length of time left to serve, to decide what program the person's most likely to benefit from and most likely to be able to complete during their period. So insofar as like holding completions of program, holding up their flow down, and it's really kind of dependent on how a sentence order might read. So if we have a suspended upon successful completion sentence for a specific program, that's going to require completion. But I don't know if the flow down question might be more related to the tracks in the R2R program. So I don't and I think that the question might have been kind of related to some of the curriculum portions of of the R2R program, where you can also participate in some of the other curriculum, like anger management, life skills, things like that. And I do not believe that working on those additional collegiate components would hold off. Well, I'm not sure. So let me pose the question to the group. We talked about the collegiate components that can be added to the personal treatment plans, such as like anger management and life skills. Would completion of those components be a part of the requirement to move through the R2R program?
I can speak to that, Heather. Typically it wouldn't, because the prescription for a particular collegiate model group would be a collaborative effort between the program participant and their primary counselor, and the length of time that they had remaining in the program would be taken into consideration when the individual starts working on that journal. Completion of a certain number of journals are a part of our benchmarks, and that's all taken into consideration as recommendations were made. Of course, we would not successfully complete someone without a plan post-release to address any needs that may linger beyond their time in the program. Does that sufficiently answer your question?
Okay, yeah, I think that's definitely helpful. I think that's part of what the requester was looking for there. Okay, so let's see.
I'm sorry, Heather. One thing that I would add is we are also in constant communication with Aftercare. So if there were additional things that would benefit the individual to work on, our team at that level of care would also be able to address those concerns.
Great, thank you. Okay, so I think this question's probably to Dr. Awe. What determines the drug selection for MAT? So we talked about the different options that we have. How is it determined who gets what?
So it's similar to what would happen in the community with a community MAT provider, where it's a shared decision-making process between the doctor and the patient. And there's lots of things that go into this shared decision-making. It's not just the doctor telling you this is what you should be on, or the patient even saying this is what I want. There's a lot of discussion. First of all, you have to look at the person's physical health. Are there other illnesses that they have that might guide you down one path versus another? And then you also have to look at the person's values and their desires. Would they feel more comfortable in a situation where they have to go in every day to get this medicine, or would they prefer monthly? And you also have to look at their prior history. How long have they been using opioids? Have they tried in the past and been successful or unsuccessful getting off of opioids? And so all of these come together in deciding which one a patient will be placed on.
Thank you. So there was another question related to distribution of naloxone, and I'm not sure that we can answer this, but we might be able to maybe point the person in the right direction for finding an answer to that. So the question was, has anyone done any work on looking at the effects of passing out naloxone? So if someone is someone experiences an overdose and is saved through naloxone, is there any follow-up study to see how that person fares in the future? Do they go into programming? Do they continue to struggle with SUD? Has there been much work done at this point studying after having naloxone?
So I know that the Division of Public Health has a whole program related to naloxone distribution, and they also have a program, I don't remember the name right now, where they look at the whole opioid use disorder epidemic, and they're tracking a whole bunch of things: the number of overdoses, the number of deaths due to overdose, how much naloxone is given out. So the person asking that question might want to reach out to the Division of Public Health because they would have the best data for Delaware.
Thank you. And next question, how long does a person generally stay on MAT? And can you be on MAT without counseling or other interventions?
So I will answer the second part of that question first. it is very much discouraged. SAMHSA has, part of SAMHSA's training, they train providers to know that this should be a holistic approach, right? So don't just medicate the person, but combine this with counseling, because that's what is most likely to give you success. And so patients should not be on MAT, just the medicines, without the counseling component. The first part is how long the person should be on the MAT. So that varies from person to person. And so this is part of the changing the thinking around substance use disorder, to where we realize that this is a chronic disease, like diabetes, high blood pressure, chronic diseases. Now, for some people, they're able to manage their diabetes or their high blood pressure. They take medicines for a couple of years and they're able to get off of it. But for many other people, they have to stay on it long term. And it's similar with substance use disorder. For some people, they will have to stay on it long term. Some people are able to successfully get off of it. And again, it's this whole shared decision-making process where you're talking with your doctor, you're talking with your counselor, and deciding what is best for you based on your health, and also on your values and on your preferences. And so I think the real focus for substance use disorder treatment is to help the person be functional, able to contribute to their family, to their job. That is the real focus versus getting the person off or not. For some people, it will be appropriate to get them off. And for some others, not necessarily. What matters is that because they're on these medicines, they're able to function at a higher level than they would be otherwise.
Great, thank you so much for that answer. That I think wraps up all the questions that we have. There are a few that that people pose that we're going to try to answer offline. I don't know if anyone has anything else they would like to add before I wrap up.
Yeah, if you don't mind, can I speak to the question about encounter groups?
Oh, sure.
So I saw someone place in the chat a question about encounter groups, so I want to give a little context before I answer the question. When you look at therapeutic communities and in-prison settings, one of the dynamics that makes the community powerful is the ability for peers to address peers. What's traditionally happened is we've allowed peers to get into a specialized dynamic where part of the dynamic is confrontation. When you break confrontation down in reference to therapeutics, it's supposed to be about addressing each other with care and concern. What has happened in the past is when residents weren't healthy, they were giving the opportunity to address concerns that were issues that were raised or brought up in them by peers. And what would happen is they would personalize the message, they would be vindictive, they would be aggressive. What was supposed to be happening in those moments is staff was supposed to have the wherewithal to redirect clients and use those as teaching moments to promote health. Unfortunately, over time, that dynamic has kind of changed into what it changed into present day. And the reason why I wanted to offer context, because I wanted to explain what we're doing now. We no longer call it integrity group or encounter group. We now call it integrity group. Differences in the group. The group runs by 4 parameters called 4 C's. One of the C's was the confrontation that people saw in the past that would get out of control. That has now been shifted to a focus on an I statement or an I message that is given when the information is delivered. We've shifted to that focus because research talks about addressing concern where you're using an I message actually takes the confrontation and the level of emotionalism out of it. More importantly, it allows the person that is getting the information to hear it. And the whole point of them sharing information with each other, peers see behaviors and attitudes about each other more than staff does. And when we promote community health, we teach them how to communicate effectively, and we teach them how to address attitudes and behavior appropriately. What it does is it empowers the individual receiving the information to drive their self-change process. All of this about encounters and addressing attitudes and behaviors, about giving information to clients so they're able to return to our communities and sustain the work that they started when they are in our programs. You heard the chief talk about them still having the workbooks and things like that. So the biggest thing is it's now scripted. They're basically reading off an iMessage slip, and that slip gives them direction on how to address it with care and concern rather than it being abusive like it's become in the past. I would argue I move around throughout the facilities. I will be directly involved in the process of helping to implement it and provide oversight throughout the state. I would encourage you, if you're an employee and you want to learn more about that process, please come watch or ask questions when I'm at your site. Thank you.
Great, thank you for following up on that. So I think that is everything for today. Again, we really appreciate everyone's participation, and we look forward to providing our next webinar in October. Be on the lookout for emails or social media posts that provide the date for the October webinar. Thank you very much to Deputy Chief Records and Dr. Awe and Directors Robinson and Johnson for helping us out today. And we hope to see everybody next time. Thank you.
Thank you.